So hello again, on behalf of the EuroELSO family, I'm welcoming you to a brand new edition of the EuroELSO Webinar series. And today we're going to talk about the very important topic of anticoagulation. We have two top experts with us today, and the first one is Max Malfertheiner from the Department of Internal Medicine 2 at the University of Regensburg in Germany. He will give the first presentation on anticoagulation ECMO standards. Then we will have a short discussion and go to the second talk given by Johnny Millar of the University of Queensland and the Institute of Experimental Medicine at Queen's University in Belfast. Hi to both of you. Thank you for sharing your expertise and your time with us. Now, to all of our participants, if you come in late, that's no problem. All of the webinars are being recorded and you can download them at the EuroELSO website or look for them at YouTube. And I encourage you to ask a lot of questions. You will be able to enter them in the tool of the webinar tool. So just give me your questions and I will forward them to our experts. So thank you once again for joining, and I'm welcoming Max as the first speaker on the standards of anticoagulation. Max, warm welcome.
Yes, thank you very much, Peter. Thank you for the invitation and the possibility to talk about anticoagulation ECMO here on the webinar. It's my pleasure. And hi to everybody. I'm from Regensburg, and so today, as Peter explained already, the webinar is split into two topics. So I will start. So I'm the normal one. If you're into English football, you know what I'm going to talk about: standards in anticoagulation. And later on, Johnny Millar will speak about future perspectives and more special things in anticoagulation. So within the next 20 minutes or so, I would like to talk about basically three topics with you. First, why do we actually need anticoagulation when we do ECMO? Then, which anticoagulant should we use? And then also, how much of monitoring do we need? And I will always talk about that from a clinical perspective, how we actually do it every day here in Regensburg. So, why do we need anticoagulation? I guess all of you are aware that as soon as we prime the machine with blood, we just get an activation of coagulation and inflammatory systems. And from that moment on, you will have some clotting within your ECMO circuit, which will then lead to worsening of your oxygenator function and possible other coagulatory effects also within the patient. So we did once a prospective study where we compared different ECMO systems. It was 3 of the bigger devices used worldwide, and we just monitored the anticoagulatory effects and the coagulation pathways within these patients over a couple of days. And on this slide, you just see that the first 5 days when somebody comes on ECMO, and you see platelets decrease, factor 12 decreases, but the fibrinogen activation happens, and you get an increase in D dimers, in factor F1, 2, and also in TAT complex, which just shows that there's a rise of fibrin degradation products. So we all know if you don't use enough anticoagulation, you will have these effects, and also if you use it, you still have the effects, and you always have to try to balance out your bleeding and coagulatory effects. Another study from my colleague here in Regensburg, from Matthias Lubnow, he once looked at what actually are technical complications on ECMO. So we looked at 265 patients, and what you see, which is already circled in red, is that for acute system exchanges, the main complication is an acute clot formation, which is not so often, but at least in 10% of cases back then it happened. And also that the oxygenator gets worse and worse over time is a problem of progressive clot formation. And we try to prolong these effects and slow them down by using anticoagulation. So this is quite clear. And if you have an ECMO program, or if you're thinking about starting to your own ECMO program, the question would be anticoagulation. Is there a standard? If you look into the guidelines of our organization, the ELSO organization, the standard anticoagulant to be used would be unfractionated heparin, and the guidelines recommend to give a bolus of 50 to 100 units per kilogram of body weight, and the monitoring that's recommended would be an ACT of 180 to 220, which you should keep and look at. That sounds quite easy, but we all know it's not that easy, and you can't do it that way in just every patient and all the time. So be aware of ECMO is a big term. You know, we have the nomenclature. We all know it's more than only VV. Yeah, we have the VAs, we have the ECHORs. There's a lot of different modes of cannulation. So there's a big diversity that we have to take into concern, and we have to look at the patients, because not every patient is the same. Not every patient has the same risks of bleeding or thrombotic events. But we'll come back to this point later on. So if you ask me, which anticoagulation should we take? The choice is quite big. So I just looked this up on, if you look up antithrombotic drugs on Wikipedia, you get quite a list of possible drugs that could help you. A lot of them have been tested ex vivo in certain systems, and only few of them are actually used in clinical practice. And the main things we are looking into these days, what people use in patients, are, of course, our gold standard heparin. Yeah, worldwide, I think most centers use heparin, unfractionated. And on the other side, you have the direct thrombin inhibitors, which would be argatroban and bivalirudin. So within the next slides, I'll just try to take you in what knowledge is there, how do they fight against each other. If you start a new program, what should you use, or is there any reason to switch? To start with argatroban, I just renewed my PubMed search yesterday. So if you look for ECMO and argatroban on PubMed, you get 27 hits. Most of them are just case reports. You know, patients that are on ECMO have a suspicion of hit, and then got switched, and these cases are reported. The two most important publications, I've just show them here. So the one by Beider-Linden in 2007 was the first, where they had, I think it was 9 patients. They switched to argatroban, and they really looked into the dosing, and their recommendation of dosing for argatroban and ECMO is still what we use in clinics, and I would recommend to have a look at. And the biggest group so far, comparing 39 patients between argatroban and heparin, is the publication by Meng et al. From 2017, so 10 years later, and we don't have much more we can show. And if you look at all these publications and all other case reports that are out there, what we can say is argatroban is feasible to use, it is effective as an anticoagulant, and it seems to be safe, or at least not unsafer than what you compare it to. Just in 2017, we here in Regensburg, we decided that we want to look deeper into this. So my colleague Christoph Visser started to switch every patient who's on VV ECMO, so from our regular heparin standard to argatroban. And these data listed here are just the first cases that we looked into and monitored what's going on. So what we did is that we decided every patient going on VV will get argatroban from September 2017 on, and this is an ongoing observation. And so far, even beyond these 14 patients that I'm showing the data here, we have the feeling that there's no real big difference. So we didn't see like an increase of the transfusions we need. We don't see any more bleedings. And of course, at one hand, you have to look about cost effectiveness, what you're used to, but also the complication rates. And this data will come out, I hope, not too far in the future, so we can give another publication to this argatroban topic. The second thrombin inhibitor that's a big deal in ECMO therapy. A couple of centers, like in Milan or other places, they love it. They say this is the best drug you could use, but the data is as sparse as for argatroban. So if you look into literature, there's a total of 78 patients you have information on. So there's still some need to produce more clinical data on this. And basically, I just listed up the two most important and biggest patient groups. But if you look into this, it's the same. At the end, you have to say it's feasible, it's effective and safe. In some parts of the world, I think bivalirudin is quite expensive. So this is also something you should take in mind. And if you now look to the pros and cons of heparin or one of the thrombin, it's like just one point, like every doctor who cares about ECMO patients knows, is the suspicion of hit. And that's the reason why a lot of case reports are out there. But all our patients, once they're on the system, I showed you in the beginning, their platelet count decreases. Yeah, and then a lot of these patients are septic or they're resuscitated. They have a lot of reasons why their platelets could go down. And the problem is you just have to look at it, and then you have heparin, and the suspicion is there, but the real risk that you find hit is quite low. It's somewhere between around 0.2%, and this is something I'm not sure if that should count for like changing the whole system. So why I think heparin is still the best choice is that there's the most experience with it. You can antagonize it. It's not affected by hepatic impairment, and it's really inexpensive. On the other side, the direct thrombin inhibitors, it's the hit point, so the heparin-induced thrombocytopenia, you just don't get it. And the other point that might play a role is it's not affected by antithrombin levels. So actually, you don't have to monitor antithrombin that much, and you could focus more on other things. So I think both things are a good choice. Everything is reasonable, and everybody can decide in his own center what kind of things he should use. Coming from which anticoagulant to the monitoring of it, if you talk to people in the ECMO world, everybody has his own recipe also for the monitoring of anticoagulation. And that's also something I would always recommend. Do what you're used to, and don't start something new. So if you measure APTT in every other patient, you shouldn't switch to ACT on ECMO patients, because you won't have the feeling for this. So just stick with what you have, and no matter what, if it's the APTT or the ACT, both are not perfect. We all know that, but at the moment, I still believe that they are the most feasible things you can do. And Johnny Millar will later talk about the more specific monitoring. Other factors we always look at: platelet count is important, plasma-free hemoglobin, D-dimers, antithrombin 3, factor 10A activity, not every day, but at least once a week, or when bleeding occurs, and fibrinogen, multiplate and rotem. I just want to mention them right now here, but we don't regularly do it. And it's also, if you have the patient, I showed you before the ELSO guideline, of course, if you have the uncomplicated ECMO patient, somebody only pulmonary ARDS, single organ failure, no bleeding complications, it's quite simple, right? We use APTT about 45 to 50, ACT you can use also, and you try to manage that, and that will be an easy patient. The other problem is they don't all appear to be easy. We have patients resuscitated, big central bleeding, already on ECMO. What do? You have lung embolisms. You need more anticoagulation. You have septic patients with disseminated intravascular coagulopathy. So what's the best mode for anticoagulation in these complicated patients? This is something I can't really tell you. Of course, if it's somebody with a lung embolism, we tend to have just higher APTT levels. Do it like in a patient who's not on ECMO, and on patients with severe sepsis, we tend to have quite low heparin levels and don't really look on the APTT. But this is always a patient-based decision on how you use your anticoagulation. So use an individual approach, and sometimes on ECMO patients, less might be more, and the bleeding complications, to my opinion, are more feared and will cause more problems normally than the coagulation within the ECMO system. How we do it in Regensburg, I told you some points of it already. So we used to use heparin in VV. Now we use it in VA, and only in certain patients with hepatic impairment, still in VV. In VA, we use it in all the patients. One question, if you start clinically a patient, is how much bolus do you use? How much heparin is already in the priming of the ECMO systems? So over the years, we tended to just lower our bolus strategy. So coming once from 5,000 units of heparin, going to 3.5, going down to 1,000. And in a lot of cases, we decide not to do the bolus in the beginning. And we're not so sure if we really use it, if we really need it, sorry. And then we usually start a heparin infusion, depending on the weight and needs of the patient, around 800 and 1,000 units per hour. This is all for adult patients. Sorry, I didn't mention this yet. We only treat adult patients, so this is what our experience lies on. And then as a monitoring, we have APTT levels where we monitor once or twice a day. So if somebody is on ECMO just newly, we will do it every 4 hours until we're there where we want to be at. If he's already 4 or 5 days on the system, stable, we also are happy if it's once a day and in a sufficient way. And also the other routine laboratory values, we measure them once a day, and only if there's a need to substitute something, we will repeat it, or if there's severe bleeding, we will do it more often a day. Else, once a day, we think is sufficient in an uncomplicated patient. For agatroban, it's we don't give any bolus. It's not recommended, and the start of infusion is the same recommended in the Guideline publication. It's only 0.2 micrograms per kilogram per minute, which is a quite small number compared to non-ECMO population, but to achieve what we need. Good. So basically, for the standards of anticoagulation, my suggestion is what you're used to, see the patients, and both also on the side of dosing and on the side of monitoring, I believe that less might be even better for the patients. So things that are beyond standards, Johnny Millar will talk about, just choosing 2 words on low molecular weight heparin, I believe on patients that are bridge to transplants, long runs, it's feasible. It's something that's good to monitor. In patients that are mobilized on ECMO, it might be helpful. And for salicylic acid, I'm not sure. I believe that there are these patients that have more platelet activation, and if you use aspirin, you will have maybe less clotting in the oxygenator. But I'm not sure which patient you should really choose to do this. But maybe also not in an acute phase, but in more like long-run ECMO systems. So thank you very much. I'm happy to answer some questions. And for the new ideas, Millar.
Thank you, Max, for your very concise presentation. It's been a pleasure, and I would like to encourage again all the participants to put in your questions. Now, Max, at the beginning of your presentation, you made a very clear point about anticoagulation, because due to your data from Regensburg, more than every 4th patient will require an oxygenator change during their ECMO run due to clot formation, either acute or in long term. So we're clear that we probably need some anticoagulation. You showed about different strategies in terms of substances and all the monitoring issues. So I'd have a question with respect to the APTT levels that we're looking for in heparinized patients. You mentioned the ELSO guideline, which says you should go to 1.5 to 2.5 of the regular APTT. If I look at my lab results, the upper level would be 41. So if I went for a 2.5 anticoagulation goal, this would put me somehow stressed. And you showed the approach that you have in Regensburg, where you have much lower levels. Maybe you want to comment on the protocol of the EOLIA trial, where they had a goal of APTT in heparinized patients between 40 and 55. Now, given that this is probably in the latest years the best study that has come out on these patients, and with this protocol, they had a great profile of complications compared to previous studies. Shouldn't this be part of the new recommendations, that we go for lower levels of APTT in heparinized patients?
Absolutely, that's a good point. I mean, the ELSO guidelines, it's hard, you know, the data is not great. The EOLIA gives us some more information, a bigger trial, which is was really needed. And of course, the focus was not on anticoagulation. And I know that Johnny will also make some points about this later on. And of course, if you look at the recent literature, you will find also publications where people have focused on lower levels of heparin. There are also some ex vivo models where you tried. And the thing is that also the biocompatibility of the devices gets better and better. So there were some changes in the last years, and I'm pretty sure, and your question is good, that this recommendation should be lowered, and that we will have less bleeding complications with lower heparin levels. And like, for example, oxygenators, they will stay good for 7, 8, 9 days, and then in median, and then we have to exchange them. So I believe that that's the point that we can live with. So to change an oxygenator because you have some, but severe bleeding in the patient is a much bigger complication and threatens the lives of the patient. So a recommendation of 1.5, or as we both use more the seconds, actually around 50 probably would be better. Yeah.
Okay. So there's another practical issue, and this is also something that we see. We have quite a lot of patients who have a PTT which is above normal without even receiving anticoagulation, and if we do some additional tests, we usually find factor 12 deficiency or lupus anticoagulants. So in centers like mine, where we don't have ACT available at the bedside, it's quite complicated to guide your heparin dose. Are there any alternative strategies on how to monitor heparin other than ACT and APT? As maybe, how about anti-10A? Is that something that's recommended? Anything you have experience with?
Yes, as I said before, so the anti-10A levels, we measure them once a week at least, or if you have bleeding complications or complications in your patient, all these, let's say, complicated patients where you have spontaneous APTTs due to sepsis or disseminated intravascular coagulopathy, I would still recommend to go with a low level of heparin. So we just give them, for example, 400 units, and just because we have fear of that thrombotic effects in the small vessels. So we give some heparin. We don't stop it at all, but the monitoring is a thing where we actually don't see a lot of factor 12 deficiency.
Okay, Max is currently hanging in there. So as long as Max has been lost, Johnny, I would like to give you some of the questions that still apply to the talk of Max. Johnny, can you hear me?
Yeah, I can hear you.
Okay. That doesn't really seem to be the case. So are you there, Max?
I'm here, yes, I can hear you perfectly.
Fantastic. So Max, there have been a couple more questions. What are your thoughts about 83 substitution in ECMO patients?
Well, we do it if it's below 70. We start to substitute it. I know in pediatric patients there are some discussions that this will increase the number of thrombotic events, but as I told you, we're only treating adult patients. So if it's below 70, we substitute it, but it's nothing that we see very frequently compared to other centers where we never really know why. What we do is that every patient, we only have like low blood flows, even like between 3 and 4 liters is more or less our maximum blood flow. And I'm not sure if you go up to 5, 6 liters, if this causes effects also on your AT3 levels and of course the von Willebrand level, that these centers tend to have more need of AT3 substitution.
Okay. So I will skip a couple of questions that are specifically directed at children. Please understand that our experts are mainly focusing on adult patients. There is another question on if you use bilirubin, how about the dosing?
Well, this is a question I can't really tell you, especially not in kids. And I'm not an expert on this because I've actually never used bilirubin. So my main experience is really on heparin and argatroban.
Okay. And would you at all means, maybe in the bleeding patients, use aminocaproic acid?
Yes, we sometimes do. We just last weekend we had a patient on VA who was just bleeding from every cannulation side and artery line, and then we use it.
Okay. And there's actually more than one question of our participants on how about using ECMO without anticoagulation at all, as there have been some reports on that. In which instances would you consider doing that, or is this maybe the future?
Well, from my personal opinion, I hope this could be the future, that you don't have to worry about the ECMO system at all about coagulation and only focus on what your patient actually needs. Of course, if you have patients that are bleeding already or trauma patients, like your coagulation is low anyway, I'm pretty sure that it's feasible to do it with no anticoagulation. I spent some time also at the CCRG in Brisbane, and I did some experiments ex vivo in with ECMO systems, where you see that also without any anticoagulation, you will have the system running for a couple of hours. But compared to systems where you use heparin, it won't be the same time. So you will have more coagulation. If your patient is in risk of severe bleeding, I would do it without any anticoagulation. And if your system plots, just be aware of how to change your oxygenator and whatever you need. And I'm pretty sure that in the future we will have more of these case reports and even some smaller series on it.
In fact, our working group has just published a small series on patients with severe thrombocytopenia managed without any anticoagulation, and we had unexpectedly few numbers of circuit changes during that time. In one patient for runtime more than 100 days, just 2 elective changes of the system. So in some patients, this really may be feasible, and we may be able to understand better in the future. Max, thank you so much for your great presentation, for the discussion. We will get you in back later for the joint discussion together with Johnny. Johnny, thank you so much for giving us your perspective on the future of anticoagulation in ECMO management. Thank you so much for being here.
Thank you very much, Peter. It's a great privilege to join you, Max, this afternoon. So Max has done a really good job about talking about anticoagulation and how we do it in clinical practice today, and we thought we'd maybe spend the second half of the webinar potentially looking to the future and what anticoagulation might look like in the next 5 years and even beyond that. These are my disclosures. So Max has already outlined the tightrope that we walk when we think about anticoagulation during ECMO, where we predominantly use systemic heparinization to avoid thrombosis, but run the risk of encountering increase in bleeding. And we're really trying to get into this middle point. I think Max quite eloquently described the challenges in getting to that place. But I think we should remember where we've come from. And this is a paper many people will recognize. This is a seminal paper from Luciano Gattinoni and others from the mid-1980s, where they had a trial of an extracorporeal CO2 device, which was in a VV configuration, had a flow rate that was around 20 to 30% of the patient's cardiac output. And again, they used unfractionated heparin, and their major complication was bleeding, and it was really quite significant. Their average whole blood transfusion rate was about 1.8 litres per day, and that's really unimaginable now with modern technology. And when we look at the EOLIA trial, again, as you said, probably the best evidence we have, certainly in VV ECMO, the incidence of major bleeding, which was defined in the EOLIA protocol as more than 10 units of red cells, or the requirement for transfusion of 10 units of red cells, was only around 2%, which when you compare that to the Gattinoni trial from the 80s is really quite a significant improvement. Much of that, I think, has been driven not by a change in our anticoagulation strategy, but by a change in technology. And again, this is a table that describes the commonly available commercial circuit modifications that we use. Many people will be familiar with the McKay Bioline, the Medtronic Cormida, which use covalently bonded heparin in the polymer surface to reduce the requirement for anticoagulation in ECMO circuits. Of course, another lesson from history, as Eddie Fan, I think, recently titled an article on ECMO mechanical ventilation, there is nothing new but that which has already been forgotten. And as long ago as 1972, a year after the first adult ECMO, people were already talking about ECMO without the need for systemic heparinization. And in this case, this was an animal study, was achieved by circuit modification. And again, this was heparin bonding the membrane oxygenator, a technique which has actually been around since the 1960s, believe it or not. The major drawback here was that they needed to use a solvent, and that was toluene, which many of you who are old enough to remember glue sniffing will recognize. And when toluene leaches out, which it eventually did, they ended up with some pretty spectacular biochemical consequences. So in the near future, how are we going to move things forward? And I think in the next few years, that's probably not going to be by a rapid change in technology, but by us trying to modify this curve. And we've touched on that in the last discussion, which how can we push ourselves towards lower anticoagulation, still avoiding significant thrombosis, but getting further and further away from bleeding. And potentially there are certain circumstances, I think, in which we can avoid anticoagulation or systemic anticoagulation at all, again, in quite specific areas. So what do most people do? These are two fairly recent surveys of ECMO centres across the world. On the left-hand side, adult patients. On the right-hand side, Gail Anich's work, which is a little bit older now, but was predominantly in paediatric patients. And you can see that the vast majority of centres are targeting, which I think are now relatively conservative ACT values, somewhere between 160 and 220 seconds. I think in paediatrics there is much more concern for coagulation. You can see that their minimum ACT goal is probably a little higher than you would see in most adult centres now. But I think these are fairly consistent, would be recognisable to somebody who's doing ECMO in the 90s. And there potentially is some evidence that we could get a little bit more liberal. So this is a very recent publication from Australia, which is the pilot study of HELP ECMO, a trial of low-dose heparin strategy versus a fairly conventional strategy. So the low-dose group that targeted an APTT of less than 45 seconds. Small study, included VV and VA patients, only 32 patients in the trial, but you can see they achieved some separation, probably not as much as they would have liked, but there was a significant difference in the daily dose of heparin, both by body weight and overall. And this from the supplement, although this is a pilot study and it's certainly not powered to detect any difference in these outcomes, but this is their incidence of thrombosis. So the left-hand column of figures is the low-dose group, the right-hand column, the standard group. You can see that there was no real difference between the two groups, suggesting that lower dose heparin with a lower APTT target may be feasible without a major increase in the rate of thrombosis. There's other observational data to back this up. So this is a retrospective study from Korea, where again they had two varying ACT targets, again systemic heparinization, ACT of 140 to 160, and they showed that much less bleeding, but with no real difference in thrombosis. Again, there is nothing new in ECMO. This is a study from 1991 where people were talking again about being able to do ECMO without heparin, both in animals and in this paper in a small series of pediatric patients. And again, in the no heparin group, you see ACT targets that are pretty low. There are other circumstances where we may be able to get away with without systemic anticoagulation at all. Trauma and traumatic brain injury is probably the most well-recognized area. Two reasonable size series from Germany. The first, the lower one from Max's group in Regensburg, where in certain trauma patients they will initially start heparin free and then only revert to heparin once they're sure that the bleeding has stopped and the patient has been adequately resuscitated. They didn't see any difference in the rate of thrombosis in these patients, and that's been backed up by a number of other case series, both from Europe and from North America. So certainly in the trauma patient, the patient with traumatic brain injury, there may be a suggestion that at least initial heparin free ECMO may be feasible and may be safe. We also touched on this in the discussion that lung transplantation, both as a bridge to lung transplant VV and more recently, people have described anticoagulation-free VA ECMO for peri-procedural lung transplant may also be an area in which we could get away with that. And I think, Peter, in Vienna, there's a lot of experience with getting away without systemic anticoagulation and perhaps only using prophylactic doses. So this is an area I think there's a lot left to explore. Unfortunately, I don't think we're going to get a big trial here, a big head-to-head trial. The HELP ECMO full-scale study is going to be about 200 patients. That's underway in Australia, and hopefully we'll have some results from that. But I think we've got to be smarter about how we do this. And the one way that we might achieve this is being clever about how we do trials within registries. And this is Carol Hodgson, many of you will recognize from Melbourne, and she has up and running in Australia the EXCEL study, which is a comprehensive registry that collects very granular data. And if this was to be rolled out in conjunction with the ELSO database, it may be that we can use clever trial designs to assess varying strategies, including low heparin dose and lower targets. And I think that's something that's going to come along in the next few years. So how else can we get away from all the problems of anticoagulation? Max talked about HIT. We've also got problems with heparin resistance. Is there a way that we can maybe not change the technology as such, but we can shift this curve to the left? And one way might be novel anticoagulants. So to think about novel anticoagulants, we're not talking about even the direct thrombin inhibitors here. We're talking about drugs that are still under investigation. We've got to think about what's actually driving coagulation during ECMO. And we've got to remember that it is the exposure of blood to the artificial surface of the circuitry and the components. And that's really driven not by thrombin-dependent mechanisms, and really that's what our drugs are targeting. Heparin and DTIs target thrombin, but it's being driven by factor 12, the contact system, and that has a lot of knock-on effects both on platelet function, which we haven't really addressed, and also in the inflammatory response. So is there a way we can get closer to the problem? And this is a good way to look at it. So the ways we might be able to do that are to get right to factor 12, which is the start of the contact cascade, and inhibit it there, and also to explore areas that we haven't really addressed, which is probably the role of platelets in coagulation. So factor 12 inhibitors are a thing. They are in various stages of translation, but they have been tried in models of ECMO. So this is a fairly recent study of a factor 12A inhibitory antibody in a rabbit model of ECMO. And you can see that when we look at bleeding, it seems to be much superior to heparin and almost very similar to a control, which was saline, and it's able to do that without running into problems with thrombosis. So on the top left, you can see a figure that shows trans-oxygenator pressure gradient, which stays very similar between heparin and the antibody over a fairly short ECMO run. And then electron microscopy shows us that it really prevents a lot of fibrin deposition and platelet aggregation on the membrane bundle, and that's backed up again by measuring fibrin deposition. So it seems that in these animal models that inhibiting factor 12, so getting that contact cascade right at its origin, can prevent the need to use heparin and inhibit the thrombin, which obviates the risk of bleeding but prevents thrombosis. There's lots of ways you can inhibit factor 12A. Antibodies are probably the most studied way, but there are also biological inhibitors. There are small molecules and there are oligonucleotides. There's a range of these that are in clinical translation, and I think we're going to see these come along soon. Max has done some work with a factor 12 inhibitory antibody in an ex vivo ECMO setting, and hopefully we'll see the results of that soon, but we'll shortly, I think, be moving towards clinical trials, and this would be a great drug if it were to become available. The other way we've talked about is perhaps attacking platelets. Nitric oxide is probably the most studied way of doing that, but people have now started to think about using anti-platelet drugs, and there is some experience both in Paris and again in Regensburg, of using aspirin in addition to heparin anticoagulation to try and target platelets, and that seems to be both safe and confer an additional benefit over heparin alone. Other centres have, in a retrospective fashion, have looked at patients who were on dual antiplatelet therapy for other reasons and how they did an ECMO, and haven't been able to show any real significant difference in bleeding rate, which is encouraging. So I think this is another area that we'll start to see more case series and may see some progression in, is the concomitant use of antiplatelet therapy in addition to our current anticoagulation strategies. All of these things are about trying to move on that tightrope, but is there a way we can just get rid of this completely, obviate the need for anticoagulation, obviate the risk of bleeding, or obviate the risk of thrombosis? And the way we might be able to do that is by making more and more sophisticated modifications to the surface of our devices. So again, we go back to the underlying pathophysiology, and what sets all of this off is fibrin and protein deposition on the artificial surface. And if we can prevent that, and we can prevent the ensuing coagulatory cascade, then we would remove the need for any pharmacological intervention. So there are really three ways you can do that. Surface passivation, which has been around for a long time, which is trying to make the surface of the component more biocompatible. We can also try to induce biomimetic functions on the components. Again, heparin bonding has been around since the dawn of ECMO, and a lot of people spend a lot of time trying to introduce other agents. Nitric oxide is probably the best studied, and more recently and most excitingly, people have tried to introduce direct thrombin inhibitor binding to the surface of the components. And then in the future, this is certainly not for prime time, but endothelializing the ECMO circuit and components is probably the ultimate destination. There's a couple of ways of doing that we'll come to. So again, this is not new, but it is an area that is moving forward, and we already have a number of these surface modifications, some of which are biomimetic, like the anticoagulants, some of which are passivation, like albumin. But as I said, nitric oxide is the one that really has engendered the most research activity, and Gail Anich and Bob Bartlett have really driven this. So this is a study from about 10 years ago now in critical care from Gail. And when you look at the figure on the left, the two bottom groups are a group that had a heparin or a ECMO circuit that leached nitric oxide at the surface with heparin and without heparin, and the top two groups are without the nitric oxide. And you can show that the addition of nitric oxide to the surface of the components reduces platelet activation, and they've backed that up with imaging studies. Nitric oxide containing polymers have gone through a number of generational iterations, and the more modern ones combine both biopassivation and also the biomimetic functions of nitric oxide, and they seem to perform even better than nitric oxide alone. This is work from Keith Cook. Most recently, people have actually started to develop membrane fibers that include copper-based electrodes that then secrete are responsible for the release of nitric oxide. So this is a study in animals. This is really exciting, where you can actually build the generation capacity of nitric oxide into the oxygenator, which we know is the site of maximum inflammation, maximum coagulation, and where the risk of thrombosis is potentially highest. So this is probably the state of the art at the moment. As I said, really excitingly, people have progressed from nitric oxide to thinking about, could we put something like our Gatraban into the surface of the circuitry, so it's not leaking, it's not becoming systemic, it's just on the surface of the tubing. And here you can see again in a basic science study, on the left is the control, on the right is the polymer that has or Gatraban embedded in it, and you can see the difference in clotting. So again, this is state of the art. This may be coming down the line soon. So circuitry with our Gatraban actually built into the polymer surface. And as I said, in the future, endothelializing the circuit may be our end point. There's two ways of doing that: in vitro, where it's done on the benchtop, so you endothelialize the entire circuit and then you send it out to the clinic, or in vivo, where you put the patient on and then you induce endothelialization. In vitro is really difficult. It's associated with a lot of problems, not the least of which is keeping the circuit sterile. In vivo is potentially much more attractive, and with an increasing knowledge of endothelial progenitor cells and our ability to engineer them and manipulate them, this is something that could become reality, certainly in the next 5 to 10 years. And many of you who work in the cardiac field will know that this is not science fiction, that this, certainly in the cardiology world, is science reality. When modern cardiac stents are incorporating this technology. So this is this results from a study of a stent called the combo stent, which is has a traditional drug-eluting component to it with sirolimus, but it's also coated with an anti-CD34 antibody, which basically encourages endogenous endothelial progenitor cells to deposit themselves on the stent. And they've shown that over what is probably too long at the moment for temporary ECMO support, over 3 months to a year, that you can fully endothelialize these stents, and they outperform traditional drug-eluting stents. So as our ability to engineer EPCs, as our ability to manipulate induced pluripotent stem cells improves, and we can speed this process up, endothelialization, in situ endothelialization of ECMO componentry and the oxygenator may become a real thing. The other thing we've got to talk about is personalized coagulation management. So Max gave us a recipe for anticoagulating patients. And he did allude to the fact that everybody's different. VA is different from VV. Patients with ARDS are different from patients who are on a bridge to lung transplant. But how can we actually start to tease out what these groups are? And many of you will be familiar with Carolyn Calfee from San Francisco's work in ARDS, where she's used machine learning techniques to identify 2 separate phenotypes in clinical trials of ARDS, a hypoinflammatory group and a hyperinflammatory group. And this is really based on a number of biomarkers. And you can see that platelets are really important in distinguishing these 2 groups. They have very different mortalities and they respond to treatments in different ways. And undoubtedly, this may be similar in ECMO patients. So Max and I together have done some work in VV ECMO from the Regensburg database, where we've replicated Carolyn's techniques, about 400 patients using a number of clinical biomarkers. And you'll have to bear with me here. This is the latent class analysis, a kind of unsupervised machine learning technique that we replicated, or came close to replicating Carolyn's results. So again, we saw 2 distinct classes who have very similar distribution. About 66% of them are hypoinflammatory, about 33% are hyperinflammatory. And again, our markers are very similar to those seen in Carolyn's work. So platelets, again, a very distinguishing feature between these 2 groups, both before and after 24 hours of ECMO. They have very different survival. So if you're in the hypoinflammatory group, you're much more likely to survive. If you're in the hyperinflammatory group, your odds ratio, even before you go on ECMO, is about 1.7 of death. And if you're still in that group on day 1, your survival is pretty poor. So that's just over 40% on VV. These phenotypes are being found in lots of critical illnesses. This is work from one of my collaborators, Kenny Bailey at the Roslin Institute in Edinburgh, where they've done this in pancreatitis, and they've taken it a step further. We've got the conventional way of classifying pancreatitis into sort of mild, moderate, severe, based on a number of factors. And he's actually suggested that we look at individualized systemic trajectories of injury, and he's done that by collecting a number of markers, clinical, metabolomics, transcriptomics, proteomics, and found that there are probably around 4 distinct subtypes of pancreatitis, and they all behave differently and they all have very different markers. So I think that's probably likely to be true for anticoagulation in ECMO. So if you imagine this is, we've got rid of the tightrope of thrombosis and bleeding, and now we've got these individual groups. So you've got a group who are at high risk of bleeding, you've got a group who are at high risk of thrombosis, you've got a group who are paradoxically at risk of both, and then you've got most comers in the middle. And there are going to be ways, whether they be clinical, they be genomic, they be proteomic or metabolomic, of identifying these patients and then delivering tailored anticoagulation strategies. And I think with the rapid advance in machine learning, we're going to start to identify these quite soon. So in summary, what's ECMO in 2025 going to look like? I think that in the next 5 years, the circuit and the device choice might be tailored to a patient's multi-nomic endotype. Circuits are going to become increasingly biocompatible, and we may start to have drug-eluting components or certainly components that are bonded with drugs beyond heparin, such as argatroban or nitric oxide. I think there's going to be an improvement in our real-time integrated cellular hemostasis, and we haven't really talked about advances in thromboelastography and platelet monitoring, but I think they're going to become much more of a common feature of our units. I think by 2025 there's going to be minimal thrombosis and probably minimal bleeding without the need for certainly the high dose of systemic anticoagulation that has been traditional on ECMO. I think the requirement for component exchange is going to reduce, and circuits are going to last longer. And I think we give it time, and we look at Moore's law in computing, and biotech is going rapidly the same way, that potentially within the next 10 years, we may have come up with a way of fully endothelializing circuits in a time frame that's suitable for ECMO. So I think the next 5 to 10 years is going to be exciting, and I think that things are going to change quite rapidly. Thanks very much.
Johnny, thank you so much for giving your idea and your perspective of a better ECMO world in the year of 2025. You've talked about low versus high anticoagulation goal strategies. You've talked about new agents. You've talked about the latest stand in the development of new artificial surfaces, and also about the very exciting approach of a personalized anticoagulation strategy. So, Johnny, if you had to make a personal guess, what could be the first of the several new kids on the block that you had mentioned that could get into effect and become a part of clinical practice in the future?
I think first of all, we're probably quite, at least in adult practice, we're going to rapidly move towards lower targets. I think we've realized that we just don't need the 2.5-fold increase in APTT, that we can get away with much less anticoagulation. I think that's going to happen. I think it's already happening. I think a lot of centers have moved towards that. I know in Vienna there's a lot of experience now with patients, particularly in the lung transplant ward, who are receiving prophylactic anticoagulation alone. So I think that's going to be the first thing that's going to happen. I think that the very near future will bring circuits that have new drugs and agents bound to them. So I think that our argatroban bound into the polymer is really exciting, and I think that nitric oxide has been in the pipeline for a long time and probably will come soon. I think things like endothelialization are potentially further away. I think there's a lot of challenges to overcome there from an engineering point of view, particularly because in the VAD world, in the MCS world, or in the cardiology world, you can have a year for cells to take and endothelialize, but that's no use when the median duration of EV-ECMO is 7 days. It needs to happen day one, and that's a big engineering challenge to overcome. So I think these things will come step by step. I think the first we'll get better at managing what we've got, and I think then we'll get some new circuits.
All right. So thank you so much for your presentation, Johnny. It's been really, really exciting. And I would like to pass maybe a final question first to Max and then to Johnny again. Max, what's your perspective on the talk of Johnny's? What are your thoughts and anything you would want to point out on that one?
Well, as Johnny said, there are some new coatings that will come, which I think will be one big thing towards an ECMO without heparinization or without anticoagulation. myself, I did some experiments with factor 12 antibody with nitric oxide in systems. Well, there are some good aspects about it, but there's no breakthrough yet. So I believe that the biocompatibility can only be like improved by better coatings, and if we get there, this will be a step ahead. You know, make our oxygenators give them a longer life and don't affect the patients too much. With the nitric oxide, with the gases that you could add, I'm not sure. I mean, you will always have some systemic effects, probably. It won't only stay in the system, so we'll see how far we can get with that. But certainly some very interesting pathways we can have a look into and see what the future brings.
All right, Johnny, anything you would want to add, summing up this webinar as we have crossed the hour?
Yeah, no, look, I think the way we started to talk, I think the future is very exciting, but I think we'll have to recognize how far we've come when you look back to that Gatnoni Passante Colombo paper from 1986, when patients were having 2 liters a day blood transfusion therapy that is now associated with relatively controllable risk. Things have moved fairly rapidly in the 30 or 40 years, and I think in 30 or 40 years time it'll be unrecognizable.
Do you see any protocols that interested colleagues could join that are currently going on, like multicentric things?
So I think this is really difficult. So I've talked about Help ECMO, which is running in Australia, and that's supported by ECMONet, which is a global ECMO clinical trials group, but it is in Australia alone. There are, I know, a number of US, North American trials of direct thrombin inhibitors, which are fairly small, but I think anticoagulation is still an area where the community has to get together and think about what are the most important studies and how can we do those as a community. I think there's still room for us to decide on that.
Okay, so finally, we may want to mention that there's currently a prospective observational study going on that's run by our colleagues from Palermo in Italy. That's a PROTECMO study endorsed by the ESA-ICM, and that's primarily looking at transfusion practice, but also on the relationship between anticoagulation strategies and outcomes. So if you want to join, I think it's still time to do so. Get in touch with the colleagues. Max and Johnny, thank you so much for taking all the efforts and for giving your time and expertise to enlighten us on these issues. It's been a great pleasure. Thank you to our participants to being very interactive and asking a lot of questions. I do want to mention that you should reserve the dates for May 6 to May 8, 2020 for our annual EuroELSO meeting in London, UK. And eventually, here are our today's final reminders. For one, you're only safe if your venous line is blueberry and your arterial line is cherryberry. And for the other, never ever forget breathing, otherwise it may cost you life. So on behalf of the EuroELSO family, this is Peter Schellongowski from Vienna, Austria. Thank you for joining. Stay tuned to EuroELSO and goodbye for today.
Bye.
Thanks, Peter.
Thanks.